Good evening, everyone. Thank you very much for attending our KSA bi-monthly webinar. I think in the interest of time, we are going to go ahead and start. I see we already have so far 90 participants. And our topic for today is anesthesia and anticonvulsants. Our presenter for today is Dr. Gatheru, who is a consultant anesthesiologist. He's a lecturer at the University of Nairobi. He is a father and also a part-time farmer. And our sponsors for today are Sanofi. So without further ado, I'd like to welcome Dr. Gatheru. Can go ahead and present. As usual, as Dr. is presenting, if anyone has a question, feel free to drop a comment in the chat box. So Dr. Gatheru, karibu.
Thank you, Teddy. And thank you all for this opportunity to discuss about anticonvulsants and anesthesia, because this is something that we encounter in our daily practice. As I begin this talk, I'd like to say that my house is near Wilson Airport, and occasionally you'll hear some planes flying past, but not too much of a bother. You should be able to hear me well. Yeah, so we're going to talk about anesthesia and anticonvulsants. And we start with some simple definitions. Sometimes when we talk about anticonvulsants, we have some words, antiepileptics, seizures. These are words that we talk about all the time, sometimes interchangeably. So a seizure, from the Latin word sacia, is to take possession of, because when people had seizures, then they would say they were possessed, much as what we do now here in Africa. So these are clinical manifestation of abnormal excessive hypersynchronous discharge of a population of cortical neurons. When we have a disorder of seizures, that is what we call epilepsy. So it's a disorder characterized by recurrent seizures and provoked by an acute systemic or neurologic insult. Now, when the seizures are unrelenting, that is what we call status epilepticus, and we shall define this further on. Status epilepticus must be stopped because this is a medical emergency that could lead to death or permanent neuronal and consequently brain damage. So how do seizures or epilepsy come about? And in the CNS, we do have excitatory and inhibitory neurons. And when there is an imbalance between their discharges, then you are likely to have seizure activity. If the electrical discharges on the neurons cause them to be hyperexcitable, that could lead to seizure activity, or if there is reduced inhibition, or if there is inhibition of the inhibitory firing from the inhibitory neurons. The importance of this is because the anticonvulsants that we use work through these systems to have their effect on the patients. So treatment focuses on inhibiting excitatory firing or augmenting the inhibitory processes, and sometimes a combination of both. So when we have high frequency burst of action potential, we initiate a seizure. That burst will synchronize with the nearby neurons, and that's how sometimes we have focal seizures later become generalized. Once a seizure has been initiated, it needs to be propagated, and that is how it will be propagated to the surrounding areas and eventually sometimes to the whole brain to give us what we call generalized seizures. So sometimes a seizure activity occurs once and it goes away, but sometimes when we have an insult that is constantly attacking the brain, so the neurons is theorized will have some reorganization, and then epilepsy will be established. That means you'll be having frequent seizures, even if the precipitating insult sometimes has been removed. So epilepsy is quite common. And as anesthetists, we are frequently faced with epileptics or people with seizure disorders, because these people do require elective surgeries. They do sometimes require emergency surgeries for unrelated conditions, or sometimes because of their neurological issues that need to be sorted out. When we do surgical procedures in epileptics, there are some challenges that we are faced with, and we need to anticipate some of them and know how to deal with them. Epileptics also will frequently undergo several diagnostic and imaging procedures. Some of them are painful, some are uncomfortable, and many of our epileptics are children, and they may require sedation. And you know, sedation is also in the realm of anesthetists. So much of what we'll talk about epilepsy and anesthesia applies to sedation. Many of these antiepileptic medication do have interactions with anesthetics and vice versa. Anesthetic drugs also do have interactions with antiepileptic medication. So various anesthetic drug interactions with antiepileptics, intra-op and post-op seizure management, and management of status epilepticus are something that we need to be at home with, because these are things that we will encounter once in a while. So I shopped around for Kenyan figures of seizure disorders and epilepsy, and they are very, very hard to find. And I think the most recent is this study done in Kilifi, which tried to do a prevalence of epilepsy in children. The Kenyan study was basically focusing on children, and it used Kilifi to extrapolate to the rest of rural Kenya. And that is the lifetime prevalence that they came up with, 21 to 41 out of 1,000. This was in 2015, as I said. Now, lifetime epilepsy for developed countries, based on a study that was done in China, came with a figure of 5.8 individuals per 1,000 people in the population. And then globally, people who have active epilepsy are 4.9 per 1,000. Active epilepsy means these are people who are basically actively epileptic, as opposed to lifetime epilepsy, where perhaps someone had epilepsy that has since been controlled. The commonest cause, according to the Kilifi study, was birth trauma, infections, and head injuries. And that, as I said, was done in children. So epilepsy is quite common worldwide. The epidemiological data is very hard to find, and most of it is done at a point and extrapolated to the rest of the globe. So the highest incidence is at the extremes of age. Now, lamotrigine and carbamazepine are considered the drug of choice in focal epilepsies, while valproate is considered to be the most effective for primary generalized seizures, which are basically what we find commonly in our neurology clinics in Kenya. Now, the general consensus for people with epilepsy is that they are started on one antiepileptic drug. In case there are adverse effects from that drug, an alternative drug is given. Now, if the seizures are not controlled with monotherapy, then combination therapy is often necessary. And a significant proportion of epileptics from the Kenyatta Neurology Clinic are actually on 2 or 3 drugs or combinations to achieve seizure control. So there are several classifications of seizures, and this is the one that is most widely used as partial or generalized seizures. So in partial seizures, mainly you are having seizures starting from one zone in the brain, restricted to one hemisphere, and rarely do you have loss of consciousness. Sometimes partial seizures can later become generalized. In generalized seizures, both hemispheres are involved, and most times there will be loss of consciousness. There are also what we call pseudoseizures, which we shall not discuss much about, and then we will talk about status epilepticus, which is a medical emergency. So as we talk about anesthesia and anticonvulsants, we need to know a bit about the anticonvulsants that are in clinical practice today. And there is a very interesting history of how anticonvulsants came to be, and the first documented use of anticonvulsants was in 1857. That was potassium bromide, and basically the active ingredient was a bromide salt. And what then, it was generally agreed that epilepsy, and by that we mean generalized tonic-clonic seizures, was because of excessive sex drive. So they realized that by giving individuals bromide, they would basically sedate them and the sex drive would go down, but also so would be their seizure activity would go down. So that was how they correlated that seizures came because of excessive sex drive. But basically what bromide was doing was sedating these individuals. However, bromide had very unpredictable pharmacokinetics, and basically I would sedate these people for a very, very long time, such that with time it fell out of favor. Then in 1912, there was a resident in psychiatry called Alfred, who basically at that time epileptics were managed in psychiatric units. He noticed that when he gave his patients who had generalized tonic-clonic seizures phenobarbital, they would sleep and basically have a calm night. Phenobarb at that time was already in use as a sedative agent. So Alfred was actually giving phenobarbital to sedate these epileptics so that they could have a calm night. But then he discovered that seemed to cure their seizures. And from that time, phenobarb was basically used as an antiepileptic. However, the doses required meant that there was a lot of sedation. And so there was an effort to look for an agent that could control seizures without much sedation. And in 1940, phenytoin was discovered. In 1960, sodium valproate came to be in carbamazepine in 1968. And then from that time, there was generally a lull until the 90s, when now all the second generation antiepileptics were introduced. This was a push because people had discovered that there was basically a lot of toxicity from the first generation, the older antiepileptics, and a very unfavorable pharmacology from them. And so there was a push to develop kinder agents that were more predictable, that did not require frequent serum level monitoring. And that is from the 1990s that they were developed. So as I have alluded, anticonvulsants are generally classified as first generation and second generation. There are other classifications based on their mode of action and also based on their chemical structures, like barbiturates, benzodiazepines, but this is what is commonly used. First generation are basically the older antiepileptics, and the second generation are the newer ones, which have more favorable pharmacological profile. So remember what we said about seizures and how they come about. You either have excess stimulation of neurons or reduced firing of the inhibitory neurons. So I'm trying to put an arrow here, and unfortunately it is not working. But basically, if you look at that, we have a major neuron in the middle. That's the presynaptic neuron that is bringing in a stimulation. Let's say this is a hyper-excited neuron. It has been stimulated and it's discharging furiously. So it's going to release glutamate, which is basically the excitatory neurotransmitter. And that is going to be taken up by the NMDA and AMPA receptor on the postsynaptic neuron, and the excitation will be propagated. Now, for it to do this, first of all, the impulse has to come to the presynaptic membrane, and that impulse that travels down the axon, there's a role of the sodium channels, because basically for you to propagate an impulse, you need to to have an influx of positively charged ions into the axonal membrane. So by blocking those voltage-gated sodium channels, then you inhibit transmission of the impulse, which is, I don't know whether you're following me. So by inhibiting the sodium channels, the voltage-gated sodium channels, then you're going to inhibit transmission of that impulse. You can also basically stop transmission of an impulse by interfering with the release of glutamate from its vesicle. And then postsynaptically, you can also interfere with the binding of glutamate to the postsynaptic receptors. Alternatively, you can also ensure that you have a lot of the inhibitory neurotransmitter at the synaptic cleft, so that the inhibitory neurotransmitter basically inhibit the transmission of the impulse. And that is the work of the inhibitory neuron that works through the neurotransmitter GABA. And several of the anticonvulsants work by potentiating GABA. By increasing the work of the inhibitory neurotransmitter, you are basically inhibiting the transmission of the impulse. So the sodium channel blockers include carbamazepine, lamotrigine, oxcarbazepine, and phenytoin. Most of these drugs will have more than one mode of action. By the way, it's important to say that. Now, if you remember physiology, the release of the glutamate vesicles is mediated by calcium. You need an influx of calcium presynaptically for you to be able to release the vesicle. And you can basically inhibit the influx of calcium that is going to facilitate the release of glutamate by using gabapentin or pregabalin. These are agents that will interfere with the vesicle, with the glutamate vesicle pouring, and therefore you'll have less of the glutamate in the excitatory neurotransmitter at the synaptic cleft. So the thinking behind from the 90s, when they started making the new antiepileptic drugs, was because of the concerns about side effects of the first generation antiepileptics that we are going to talk about. However, here in Africa, and if you look at most of our prescriptions, most of our patients are still on the first generation antiepileptics, the ones with the many side effects. The reasons are because of cost and availability. If you take statistics from because I work to the Kenyatta Neurology Clinic, both pediatric and adult neurology clinic, very few of our patients are on the second generation antiepileptics. Now, back to anesthesia, many of our anesthetic agents affect the propensity to seizures in epileptics, and those people with no prior history of seizures. So remember, our concern is epileptics and patients who have no history of seizures. Now, patients who are taking antiepileptic drugs will many times have drug interactions. We need to consider how to dose them, how to maintain therapeutic levels of antiepileptics in the peri-op period. This is in view of the fasting instructions that we give. Most of our patients, almost all are on oral antiepileptics. We do fast our patients before surgery, but we still need to maintain therapeutic levels, and we'll discuss some of those concerns. Now, we talked about epileptic patients requiring anesthesia for normal surgeries, for diagnostics, and rarely for epilepsy surgery. The commonest epilepsy surgery that we do in our region is lesionectomy, basically removing the cause of the seizures, be it a space-occupying lesion, be it a bleed, and that's the commonest. But there are other epilepsy surgeries that are done with various or varying kinds of success. These patients do require anesthesia. So these are already epileptic patients. They do require anesthesia, and sometimes you want to provoke seizures during this epileptic surgery for you to be able to locate the zone of the seizure origin. So for our epileptics, we need to take a focused history, and in our history, we need to know what medication they are on. Most of the antiepileptics are potent enzyme inducers. That means that whatever other drugs that we shall be using, for example, antiemetics, antibiotics, will be affected by the antiepileptic drugs that these patients have been taking. We need to know about compliance to their antiepileptic drugs so that we have an idea of their therapeutic levels and whether they are well controlled. We need to know whether their seizures have been controlled, because we want to know the risk of getting intra-op seizures, and we need to know the triggers of their seizures. For many patients who have not much cognitive impairment, they can tell you what triggers seizures. So on examination, we may need to look out for seizure-related injuries. Neurological deficits need to be documented, and sometimes we need to document phenytoin-induced morphological changes, such as gingival hyperplasia, that may have an effect on our airway. Now, one of the pre-op considerations that we need to have in place is that one of the things that we need to consider is that we should not overfast our patients. Metabolic derangements, for example, acidosis is a lower seizure threshold. Ideally, the standard fasting guidelines apply, which is 6 hours solids, 4 hours breast milk, and 2 hours for clear fluids. And this should be maintained. The antiepileptic drugs should be taken as per schedule. Now, sometimes that may be challenging. For example, in emergency surgeries where the patients have not had a chance to take their antiepileptic drugs, and we may have to give them their dose intra-op, or in prolonged surgeries where the time for their antiepileptic medication occurs in the intra-op period. Now, remember, we said most of the antiepileptics are enzyme inducers, especially the first generation antiepileptics, which most of our patients are on. This needs to be taken into consideration when we are dosing most of our drugs. The enzyme inhibitors that we have is sodium valproate. This is basically will inhibit the hormone that is used in steroid genesis, and this may be important for people on oral contraceptives. So perioperatively may not be a big concern. The newer antiepileptics may have no much effect on the enzyme system, the cytochrome P450 isoenzymes, that's gabapentin, lamotrigine, and these ones we may not have to worry so much. Now, these enzyme inducers, we will also talk about them in the ICU setup, where for short surgeries where we are using drugs with good therapeutic windows like antibiotics, they may not influence much of what we alter with our medication. Intra-op, we avoid triggers of seizures such as hypoxia, hypocarbia because of cerebral hypoperfusion. So basically, we need to not hyperventilate our patient, because if we hyperventilate our patient, we have cerebral hypoperfusion, and that may trigger seizures. And then careful selection of anesthetic agents. Standard monitoring applies. There is a controversy about what is basic monitoring for epileptics. And the consensus is basically standard monitoring, which includes invasive and non-invasive blood pressure monitoring, pulse oximetry, capnography, and neuromuscular blocker monitoring. And that is what we consider standard monitoring. Now, is there a role for seizure prophylaxis? This is a very hot topic that I don't want to dwell into, because basically we are guided by local protocols. When we look at all the papers that are out there, there's no consensus on the role of seizure prophylaxis. And this is for people who are predisposed to seizures. I'm not talking about epileptics now. I'm talking about people who are not epileptic and have conditions that we think may provoke seizures, such as people with brain tumors, brain injuries, bleeds, people who have had, for example, cardiac arrest and have reperfusion injuries, people who have had an accidental dose of local anesthetics but have not had seizures. And basically, there's no role, or there is no consensus about the role of seizure prophylaxis. Now, what drugs are we going to use perioperatively for these patients who are epileptic? When it comes to our IV induction agents, Propofol, the thing we need to know is that it has excitatory effects on the CNS. If you look at the EEG after a low dose of Propofol, we have excitatory effects, but this has not been shown to have seizure activity. Actually, there's no documented seizure activity that can be attributed to Propofol. It is actually considered safe in epilepsy, can be used in epileptics as an induction agent, and it is useful in status epilepticus, ideally as an infusion. The other IV induction agent, sodium thiopenton, is also a potent anticonvulsant, even in subanesthetic doses. It is actually very useful for epileptics because it's going to increase the seizure threshold. In patients who have status epilepticus, sodium thiopenton is useful for burst suppression. What we mean is that you can use sodium thiopenton basically to break down the seizure cycle as you're waiting for therapeutic levels of the more conventional anti-epileptic agents. And this can be achieved by bolus doses or as an infusion in ICU. Of course, with sodium thiopenton, there are concerns of accumulation and toxicity, the same with Propofol. So this is best done in an ICU setup with airway secure. Ketamine is a drug that we know raises intracranial pressure and has cerebral excitatory effects. However, it's a drug best avoided in patients who have seizure disorders. But ketamine has been used successfully in status epilepticus. And in refractory status epilepticus, that means status epilepticus not abolished by the more traditional modes of managing status epilepticus. Ketamine has been used with good degrees of success. So I know we used to say ketamine is contraindicated in people with seizure disorders, but this has changed as more evidence is picked. And what happens in prolonged seizures is that the GABA receptors are basically going to be downregulated, and therefore the common first-line agents, which principally use the GABA receptors, are going to fail because the GABA receptors have been downregulated. This is the hypothesis of how ketamine is useful. NMDA receptors, on the other hand, are going to increase, and therefore that's how ketamine may be useful for treatment of refractory status epilepticus that has not responded to the more traditional agents. Now, what about inhalational agents? Inhalational agents are safe to use in epileptics. Most will cause burst suppression, meaning they're going to depress cortical excitation, which is what provokes seizures. The only exception is N-fluorine. This has epileptiform activity and lower seizure threshold, and that one should be avoided. Isoflurane and desflurane have actually been used in refractory status epilepticus. There's even a case report of halothane being used in refractory status epilepticus with success, same to sevoflurane. Now, nitrous oxide has been shown to cause epileptiform-like activity in the lab, but this has not been demonstrated in individuals. So the jury is out there about nitrous oxide. What I would do myself is, if I have medical air available, I would just avoid nitrous oxide. Now, muscle relaxants, fortunately, most of them do not cross the blood-brain barrier, and therefore the concern for them is about the dose adjustment needed for patients who have been on long-term antiepileptics because of the enzyme induction. So for the aminosteroids, you may have to dose them more frequently because of the enzyme induction that the patient has. Now, for the benzyl isoquinolones, apart from having a more predictable metabolism, there is a concern about laudanosine that basically can cause seizures. However, toxic levels are unlikely to be reached in the usual Preop environment. You probably need about 48 hours of an infusion before you get clinically significant levels that can trigger seizure activity. So they are basically safe to use in epileptics. Well, for opioids, the drug to avoid is Pathedine, because Pathedine has an active metabolite called norpethidine or normeperidine, depending on where you come from, which is epileptogenic. However, for you to get plasma levels enough to trigger a seizure, this will only occur in situations of renal clearance. In fact, the role of Pathedine and norpethidine in triggering seizures has basically been put to question, because what would happen is that people would avoid Pathedine, for example, for treatment of shivering because of that fear of seizures. But there is a concern that that fear may be overplaced because you need significant levels of norpethidine to trigger seizure activity. But better safe than sorry. So it's a drug that we generally avoid. It's been pulled out of most of our artillery for pain medication because of other concerns, and therefore it's good to know that we should avoid it for patients who are epileptic. Now, there's a concern for other dopamine antagonist antiemetics that we use perioperatively, and that is because of the extrapyramidal side effects that may be confused for seizures. But if we know in our minds that we have an epileptic, then we don't want these extrapyramidal side effects, and you are therefore safer with the other antiemetics that are widely available. Now, for local anesthetics, remember, we don't want to have local anesthesia toxicity because it can trigger seizures in itself, or it can provoke seizures in epileptics. So we must be strict with the dosing guidelines. Serum concentrations of lidocaine below 5 milligrams per ml actually may be used to treat status epilepticus in children. And there's a series, the reference is down there, where it was used to treat refractory status epilepticus, not as a first choice, of course, but for refractory status epilepticus. For the jury is out there in adults. The evidence is not convincing that you can use lignocaine IV for management of seizures. However, we know that at toxic levels of lignocaine, then it is proconvulsant and will basically cause seizures. Now, once we are done with surgery, we must continue, or we should not have interrupted the dosing regimens of antiepileptics for our patients because of the concerns of plasma levels. Fortunately, many of these drugs have IV formulations. So for those patients who have to stay NPO for a while, then we just convert their oral medication to IV medication. Carbamazepine, which is quite common, however, is not available as an IV formulation, at least locally, and therefore it can be given rectally, and that is a conversion basically that if you are that individual is taking 100 milligrams orally, then rectally they should get 125 milligrams. For phenytoin and valproate, there is no dose adjustments, so you just convert your patient to IV, and then the moment they're able to take orally, same dose, convert it to an oral formulation. Now, for patients who have stayed in ICU or who have liver disease, who may have decreased albumin levels, then you may need to do dose adjustments guided by plasma level assays. Now for status epilepticus, and this is basically, the definitions are many, but basically these are seizures that are continuous, non-abating, more than 2 minutes, and basically without return of consciousness in between. Now, status epilepticus is a vicious cycle that at the end of it will end with neuronal damage and permanent damage, and it needs to be interrupted. So if your patient is in status epilepticus in a less than an ideal setting, then the guideline is basically rectal diazepam. The first line treatment for status epilepticus is benzodiazepines. Now, if you have status epilepticus that continues despite benzodiazepines, then we give phenytoin or sodium valproate. That is what we commonly use. And a good thing to remember, it's easy to remember about the dosing of phenytoin. There's something they say about 15 and 20, that the dose is 15 to 20 milligrams per kilo. So above 20 milligrams per kilo, you're approaching toxic levels. Below 15 milligrams per kilo, you're basically underdosing that patient. So for valproate, we can also use it for status epilepticus that has been established and is unabating. Valproate tends to have a better pharmacological profile than phenytoin and less of the toxic effects. Now, if this, despite all that, you still have refractory status epilepticus, the seizures are not abating, then now you have to basically go to infusions of benzodiazepines like amidazolam infusion, sodium penton infusion. This is basically in an ICU setup because of the concerns we talked about. Propofol infusion has also been used. Ketamine infusion has been used with success. And then you can also use the inhalational agents, isoflurane and desflurane, for refractory status epilepticus. Now, the inhalational agents, of course, come with a bit of technical challenges because we routinely don't have vaporizers in our ventilators, though I hear there are modern ventilators that come with vaporizers for such indications. The concern for the penton, of course, is accumulation. Now, remember, most of the time, these drugs for refractory status epilepticus, you give sub-anesthetic doses and then titrate upwards. So I think that is my slide number 30 because I was asked to talk for about 25 minutes. Now, I want, before our sponsors come and talk, I want to give you some food for thought from what I've talked, and then maybe at the Q&A we'll discuss this. I want you to all have a look at that. These are an MCQ, true, false. That is what we are doing now. This has been covered in this talk. So just write your answers somewhere down and then we shall mention it in the Q&A. I'll give you 2 minutes to look at that question and have your answer. And that's the second one. So Dr. Ted Were, I think that is the end of my talk. I know there'll be some discussion after Nick's presentation, and that is when we will probably discuss the answers to these questions.
Thank you. Thank you very much, Dr. Gatheru, for that illuminating presentation. You've equipped us with knowledge to help us better tackle such cases. So for now, I'd like to give Dr. Gatheru a break, and I'd like to welcome our sponsors for a brief presentation. Then we can save the question and answer session for both the presenters to the end of the presentation. So I'd like to welcome Mr. Nick Omwango, who is a medical sales representative for Sanofi. Karibu, Nick.
Thank you, Dr. Were. Dr. Gatheru, if you can stop sharing the screen. I'd like to thank Dr. Gatheru for the insightful talk on on anesthesia and anticonvulsants. I'll narrow it down to one of the anticonvulsants that is commonly used in the setup. So my talk today will basically focus on the role of Epilim in management of seizures. So as I've been introduced, my name is Nico Mwango. I'm a medical representative with Sanofi. So I'll start off with the role of valproate in seizure and epilepsy management. Then I look at Epilim formulations and the dosage, especially for Epilim IV. And then the availability and partnerships that we have. Now, Epilim can be used across all age groups, from the elderly to the young. And it's important to note that seizures should not stop a patient or an epileptic patient from continuing on with their daily life. So as Sanofi, we are committed to ensure that our patients continue with their quality of life despite the various challenges, especially due to seizures that are presented to them. So when you look at Epilim, Epilim has been there for over a long period of time. And during that time, it has continued to demonstrate proof of efficacy, right from 1964, where the first clinical trial was done to demonstrate its efficacy in seizures, up to 2008. So it has a large body of evidence, and you can trust it in terms of efficacy and also safety. So regardless of seizure types or etiology, it has demonstrated quite good efficacy. Now, according to various guidelines, and this is respect to NICE guidelines, Epilim is what is can actually be known as a broad spectrum anti-epileptic drug, in the sense that it covers quite a wide range of seizures, right from generalized seizures and partial seizures, and also seizures that cannot be classified. So according to NICE guidelines of 2012, it is recommended as first line for generalized tonic-clonic seizures, absent seizures, myoclonic, tonic, atonic, and also focal with or without secondary generalization. So despite the seizure that you encounter in your setup, you can comfortably use Epilim, knowing very well that it has strong backing from guidelines. Now, Epilim also combines, like we have mentioned, a wide spectrum of efficacy. And another good characteristic of Epilim is that it has a low potential for seizure aggravation. So if we look at some of the common anti-epileptic drugs that are there in our setups, you see that, for instance, carbamazepine, it has a tendency to worsen absences, myoclonic seizures, and atonic seizures. Phenytoin also has been found to worsen absences. Phenobarbital, also at high dosage, can worsen absence seizures. Benzodiazepines also worsens atonic seizures. Vigabatrin also can worsen absence and myoclonus. Gabapentin can worsen absence and myoclonus, and lamotrigine can worsen all seizure types at higher dosages. But currently, there is no evidence that Epilim actually worsens any type of seizure. So this can be used as you can confidently use Epilim for all seizures without the fear of seizure aggravation. Now, when we look at Epilim IV, it is indicated for treatment of epileptic patients who would normally be maintained on the oral formulation. So it is, as you have seen, it is indicated in all seizure types. And this is when you compare it with other anti-epileptic drugs, it's also beneficial because you can also use it, especially when you are not sure of the seizure type you are handling. And then also it does not cause clinically significant cardiac or respiratory depression, especially hypotension and also arrhythmias. And then also epilim does not cause irritation at site of injection. It can also be injected in less than 5 minutes, and generally it has linear pharmacokinetics offering a more predictable, stable profile. And then lastly, it can be administered as with continuous infusion when repeated doses are needed. So when you look at especially the first two, you can see that epilim can actually be quite beneficial in your setup, in the sense that you won't have to actually try to understand the kind of seizure you are handling and to choose a suitable epileptic drug for the seizure, because you comfortably can use it in all seizure types. And also you don't have to be in a situation whereby you need a cardiac resuscitatory equipment, especially due to fear of cardiac or respiratory depression. When it comes to epilim IV dosage, as we have mentioned, it is used for in epileptic patients who would normally not be maintained on oral sodium. So when it comes to reconstitution of epilim IV, we advise that you inject. It comes in a 4 ml water for injection ampule and also for 100 milligrams vial. So when it comes to reconstitution, you inject the 4 ml water for injection vial into the 400 milligram vial that has the valproate, and then you're allowed to dissolve. So this vial should be reconstituted immediately prior to use, and it should be used within 24 hours. Now, when it comes to the loading dose is 400 to 800 milligrams IV. This can be given over 3 to 5 minutes. And then the maintenance dose, this can be followed by continuous or repeated infusion up to a maximum of 2,500 milligrams per day. So you load with 400 to 800 milligrams IV, depending on the weight of the patient, and also you can maintain it at up to a maximum of 2,500 milligrams per day. So immediately epilim IV is initiated. It should be noted that when practically possible, you can switch the patient to the oral formulation. And then also another segment is epilim dosage in children, in that epilim can be given in children at a dose of 20 to 30 milligrams per kg per day. And this can be increased up to a dose of 40 milligrams per kg per day, but only in patients whom plasma valproic levels can be monitored. So those are the various dosage for the various age groups, that is the adults and children. Now, when it comes to epilim availability, if you're in a mission hospital setup, we have epilim IV available at meds, and also for the public institutions, we have it at KEMSA. And even the private hospitals and pharmacies, you can find epilim available in the local distributors. And I believe it's available also in public institutions such as Kenyatta. You can find epilim IV available in Kenyatta National Hospital. So in summary, epilim has over 45 years of clinical experience, and it is distinguished by its broad spectrum, and it remains the mainstay for treatment of epilepsy in all age groups. Also, epilim is the gold standard antiepileptic drug for the treatment of children, and as we have seen, it has a low risk of causing paradoxical seizure aggravation. Now, with all this mentioned, we can comfortably say that epilim IV represents an effective and safe alternative, especially in all seizure emergency situations, with no evidence of sedation, cardiac respiratory disturbances, and hypotension. So you're free to use Epilim in your setups. So that is all, and those are my references. Back to you, Dr. Were.
Thank you very much, Nick, for that presentation. Again, I'd like to remind everyone that the chat box is open, so anyone with any question is free to post it. So far, I'm not seeing any questions. Maybe Dr. Gatheru, we could go back briefly to the MCQs that you had given us. Oh, but I'm seeing there's just a question from Dr. Munyoro, who's thanking you for the presentation and asking you to comment on the use of tramadol. She said that she also did not hear about loading anti-epileptic patient and checking levels on patients with epilepsy.
Okay, so Dr. Munyoro, thank you for that. The tramadol has been shown to lower seizure threshold. It is an epileptogenic drug. However, the number of the series that I came across of the patients whose seizures were attributable to tramadol had other factors that could also be attributed to that could have provoked the seizures. It is generally wise to avoid it in epileptics or patients who are at risk of seizure disorders. Now, about loading of anti-epileptics, and that is what I say, there's a lot of controversy because in established seizures, there's a role of a loading dose. Now, for seizure prophylaxis, the jury is out there. There's so much about it. And the people who have tried to bring back all the literature together to give a consensus, at the end of it, this is what they say. For example, in trauma status, there may be some justification for seizure prophylaxis, but then the side effects, because the other question is for how long? People have been known to, in some protocols, to have seizure prophylaxis for up to 2 years, in others, and then suffer the side effects of the numerous antiepileptics, and others up to 2 weeks, and they did not go on to develop the seizure syndromes. And while the others who had a seizure prophylaxis for up to 2 years, once the antiepileptics were stopped, they developed seizure syndromes. So there is basically no light as to, and therefore we are guided by the local protocols. For example, in our hospital in Kenyatta, we do seizure prophylaxis for patients who have traumatic brain injuries. Whether it is based on evidence and science, I cannot comment about it. Now, I'm trying to load the questions as Dr. Were, you can proceed as I load the...
So there was also, there's a question from Tawanda Ngwenya, who asks if there's any role for magnesium sulfate in status epilepticus.
Yes, there is. There's a role for magnesium sulfate in refractory status epilepticus. That is there is what we call the consensus, the international, I'm trying to remember the name of that body. So there is a role, and it has been used with success. The only question is about other easier to administer agents that are available. Just a minute, Were, I'm trying to get the... Okay, I think I have it.
No problem. So thank you. So Clifford Muita asks if there's a role for intra-op EEG for patients in surgery.
Okay, Clifford, what has been used because the dilemma that people have in surgery is identifying intraop seizures, especially in patients who are already paralyzed. And the hemodynamic parameters sometimes can be misleading. So this monitoring has been used, and there's a case series two case reports of where BISP has identified intraop seizures, because it is technically feasible to do bispectral index monitoring intraop. Now for epilepsy surgery, where they are trying to identify the lesion, there has been some use of not really what you would call EEG. Just a minute. So intraop EEG monitoring is not standard of care for both epileptics and patients at risk of seizures. Remember, EEG requires some degree of cortical activity, that there'll be a lot of interplay with the many many anesthetics that give conflicting readings on EEG. For example, propofol induces epileptiform activities at low doses or on EEG. So EEG in anesthesia is used more for research purposes. Bispectral index monitoring can give an idea of seizure activity intraop for patients who are paralyzed, but hemodynamic monitoring can also assist in identifying seizures intraop.
Okay, thank you for the response. So far, there are no further questions, but people, again, you're still free to post any questions in the chat box. So maybe Dr. Gatheru, we can finish up with the multiple choice questions.
Okay, so if you remember the first question that we asked, well, I'll not project my slide again, I'll just read it for you. Regarding induction and maintenance of anesthesia, thiopenton has minor anticonvulsant activity. So if you said true, that is false, because thiopenton has major anticonvulsant activity. Propofol is not an appropriate induction agent. In well-controlled epileptics, we said propofol is appropriate. Initially, it was thought not to be because of the epileptiform activity on EEG, but now we know it is safe in epileptics, in well-controlled epileptics. Ketamine can cause cerebral excitatory effects in well-controlled epileptics. If you said true, that is correct. It causes excitatory effects in everyone, not just well-controlled epileptics. Halothane can cause epileptiform activity. If you said false, that's correct. Halothane does not. The inhalational agent that is implicated in this, as we said, is enflurane. And we also said that in lab rats, nitrous oxide has also been shown to have a similar activity, but not in humans. Muscle relaxants stop seizures. That is not true. They just hide the physical manifestation of seizures, but the seizure activity will continue. Now, the next question was regarding the pharmacokinetics of muscle relaxant. Vecuronium, rocuronium, and mivacurium are metabolized in the liver. So if you said true, that is not correct, because mivacurium is not. Carbamazepine will cause prolonged duration of effect of aminosteroid muscle relaxants. Maybe Were can take that one.
Dr. You caught me off guard, boy. Well, I would say true.
Yeah, because carbamazepine is a potent enzyme inducer, so it will not cause prolonged duration. It will cause reduced duration. Remember, it is an enzyme inducer. Enzyme inducers will break down will encourage breakdown of the drug faster, and therefore it will prolong it will reduce the duration of effect, and therefore you may have to dose more frequently.
Oh, thank you. Thank you for that. So I'm seeing in the chat box there are no questions, and I'm looking at the time. We've already hit an hour. So I'd like to take this opportunity to thank the presenter, Dr. Gatheru, for this wonderful presentation. I'd like to appreciate the KSA Webinar organizing team. I'd also like to thank Nick Omwango and his team from Sanofi for sponsoring this presentation. I'd like to thank all the participants who logged into the session from Nairobi all the way to Bulawayo. I'd like to inform you that all this presentation was recorded, and the presentations are going to be uploaded onto the KSA website, the KSA YouTube page, and also the Facebook page. For the Kenyan doctors, they're going to be CPD points are going to be sent on their emails. Then for non-locals and nurses and clinical officers, certificates are going to be issued in due course. The next presentation will be on the 10th of June, and it will be on TIVA, total intravenous anesthesia and target controlled infusion. And further information is going to be provided in due course. So without further ado, I think I'd like to thank you for attending the presentation. Thank you, Dr. Gatheru, again. And I think we're free to leave at a pleasure. Thank you.